So the first presentation is Targeted Intraoperative Radiotherapy, the U.S. Phase 4 Registry trial. It was a registry trial with the use of Target in early stage breast cancer, which is basically the same population that we use to treat in the Target A trial. As you see, I'm from Los Angeles. I'm part of John Wayne Cancer Institute, but I actually perform intraoperative therapy and outside of the cancer center in the surgery center setting, and have been a Target user for the last now 12 years, and was one of the U.S. researchers on the Target A trial. But this trial, the Target U.S. trial, was a different experience, and I must credit my co-PIs, Mike Alvarado, whom I mentioned, also Eleanor Harris, Bill Small, and Stephen Grobmeyer, who worked together over several years to put together a registry trial, a U.S.-based registry trial. As you know, the impetus of this, and by the way, this was funded by Zeiss, but sponsored by the UCSF. The impetus of this was the anticipated closure of the Target A trial. This is actually the first publication of the Target A trial, which came out in 2010. It was a randomized trial of, which you well know about because, of course, it was just reviewed for you in detail, and many of you are using it as well, using Target on the basis of this trial. But when the trial was conducted, we anticipated that the closure of the trial in 2012 would eliminate the possibility of continuing patients of continuing to offer patients Target treatment. With trial closure, there was concern that the doors would close and that we would not be able to continue the treatment. In my own personal institute, I was at USC at the time. We felt that the data from Target trial was sufficient to begin offering treatment as standard of care, and we did. So a registry trial or a follow-on trial wasn't essential in my own experience at my own institution. But for many institutions, they anticipated that closure of the trial would close the door for Target. So many of us over several years, the co-PIs, began to work on the development of a registry trial, which would allow institutions to have a fallback trial, an alternate trial, which would enable them to continue enrollment of patients. The Target A trial enrolled its last patient in July 2012, and the Target US trial began offering Target. In fact, the first patient was treated May 29th, 2012. So we actually were able to prevent a gap between the two trials. Of course, the Target A initial publication in 2010 was followed by the 2013 publication of the 3,400 patients. But by then, we were well on our way to offering Target and the Target US Registry trial. And so the presentation that's to come will summarize some of the findings from the US Registry trial. Another reason for considering a US-based trial is that most of the data from the Target A trial were international data. As you see from this slide, only about 7 or 8% of patients on the Target A Registry trial were US-based patients. They don't have to be patients treated in the U.S., but politically and for other reasons, it was felt necessary to have a trial that was U.S.-based because we had lots of opposition to Target, as you well know, and having patients treated here, having physicians treating patients here would facilitate the adoption of Target, and that's what we're beginning to see. So Target US Registry was a pragmatic registry, basically using the same inclusion criteria as a Target A trial. And we anticipated that some patients would also require whole breast radiotherapy, just as they did in the Target A trial. But the primary goal was to give patients Target as the primary therapy, with only those with adverse findings being treated with subsequent whole breast radiotherapy. The principal objective was to look at the efficacy and toxicity of Target. But we also wanted to look at other considerations: regional nodal failure, relapse, and overall survival. I will present in this talk the toxicity data. I must confess that we're not prepared to present local recurrence data, but maybe you might have a question about it at the end that I will address. But the basic schema was this. Now remember, this is a non-randomized single-arm trial of Target alone. Patients underwent wide local excision with definitive resection of their tumor. They underwent a sentinel biopsy because these were all invasive cancers, and they received Target at the time of the initial operation. That was the intent. And we'll talk about that in a moment, but that was the basic approach. Based upon the pathology findings, patients received either no additional radiotherapy and went on to follow-up. If they had invasive lobular cancer or extensive lobular carcinoma or other adverse criteria, they went on to receive whole breast radiotherapy. So there was a subset of patients that did receive whole breast radiotherapy based upon their pathology, and then they went on to follow up. And then there was a second possibility, another possibility of patients having positive margins that underwent re-excision or mastectomy if desired. Those that underwent re-excision underwent subsequent whole breast radiotherapy followed by follow-up. The inclusion criteria are shown here. Clinical T1 and T2 tumors, clinically no negative patients, no evidence of distant metastasis, unifocal lesions, invasive ductal carcinoma, and age 45 and older. Now, the exclusion criteria shown here, women under the age of 45 were not offered treatment, and of course all the things that you would expect, no positive disease, larger tumors, more than 3.5 centimeters, pure DCIS, EIC, multicentric tumors, bilateral breast cancer at presentation, ipsilateral breast tumor recurrence, BRCA mutations or similar pathogenic mutations, neoadjuvant systemic therapy. All of these were exclusions. And what we did after the initial sort of iterations of the trial was to close off the opportunity for patients to have target at a significantly delayed time. Now, in fact, when we initially planned the trial, there had not been a publication of the data that showed that a post-pathology treatment resulted in an inferior result. So we actually had planned to include those patients in the trial, but ultimately we decided, based upon the inferior post-pathology data, that we would restrict the trial to the pre-pathology setting. This is the post-pathology data that I mentioned, where the post-pathology results showed higher recurrences, 5.4 in the target arm versus 1.7 in the whole breast radiotherapy arm. And so on the basis of this finding, which came out in the second publication, the target trial, we decided to limit enrollment to patients treated only in the pre-pathology setting. We also had a second cohort, which was to include patients that had a history of contralateral breast cancer. None of the current breast-conserving therapy trials enroll patients that have had a history of breast cancer in the breast, but we felt that that at least from a local recurrence perspective, it was still a valid option to offer patients target in one breast or target in the opposite breast if they presented with a contralateral breast recurrence. So we do have a subset of patients in the trial that have a history of breast cancer in one breast who presented with contralateral breast cancer and received target for that cancer. I don't have any outcome data to present regarding those patients, but they are captured in the trial. So in summary, all patients received target at the initial time of surgery. They underwent whole breast radiotherapy if they needed a re-excision of the margin or if they had inferior margin characteristics, inferior adverse pathology criteria. The planned enrollment was 755 patients with built-in of additional enrollments for anticipated fallout. So the total goal was to enroll up to 793 patients. The trial is actually still enrolling patients at this time, although we've exceeded which you'll see, the accrual of 793. The decision was to leave the trial open for a little longer, but without research support for those institutions that needed to maintain access to a registry in order to enable target treatment. This is how patients were managed. Again, I've suggested this already, but if they had positive margins, and that was defined locally by institution, the patients underwent re-excision and whole breast radiotherapy without an additional boost, or if they opted for mastectomy instead, or needed mastectomy instead. There was patients with high-risk pathology underwent whole breast radiotherapy, again without additional boost, or mastectomy if desired or needed. And then there was whole breast radiotherapy, which was prescribed within 9 weeks of surgery, or within 5 weeks, or after 5 weeks of chemo, or after a 5-week interval following chemotherapy if chemotherapy were needed. You can see the radiation regimens there. Hyperfractionation was not allowed in this trial. I know there's an interest in that, but it was not allowed in the trial. The follow-up consisted of semiannual follow-ups for 3 years and yearly in year 4 and 5, semiannual mammograms for the first 3 years, then yearly All patients had to have a histological confirmation of recurrence if they developed one, or one was suspected, and patient toxicity was reported using the CTCAE version 4. This slide shows the participating centers. There were a total of 23 centers participating in the registry. You can see that some are highlighted in red. Those are ones that enrolled more than 50 patients on the site, but there were high levels of enrollment across the sites. I'll now present some of the results. Again, I'm focusing primarily on the toxicity data, not the local recurrence data. The average follow-up was of the participants in the trial was 467 days. It's such a median of 380 days, or a median of 13 months, with a range shown there. As you can see from this, the majority of patients had target as the definitive therapy. 758 patients, or 674 specifically, received target, and 114 patients received target followed by whole breast radiotherapy because of either positive margins or adverse pathology. Demographic and clinical characteristics are shown on this slide. Patient age between the target and the target EBR groups was fairly similar, 66, 64 years. The mean tumor size, 13 millimeters in the target group. Target plus EBE group, they were slightly larger, 13 millimeters. I don't know if this is statistically significant, but this is what we've observed at this moment. And I'd just like to emphasize that the trial is still ongoing. We're still collecting data, so as you'll see in some of the subsequent slides, there's a significant quantity of missing information that I can't provide, but will be provided in the future. And as you can see, the majority of patients were postmenopausal. Clinical characteristics, I've already described the tumor size, but the grade, you can see that the lion's share of patients had low to intermediate grade disease based upon data that we have collected. So at least for those for whom we have data, 70% of patients to 80% of patients had grade 1 and grade 2 tumors, but we have a significant number of patients with unknown that just hasn't been provided to us yet. 20 to 30% of patients, we just don't have enough data on them quite yet to say. But clearly the majority of patients have low to intermediate grade tumor based upon this information. And that number is likely to grow once we collect more data. In terms of node involvement, again, there's a significant number of patients with missing data, but at least for the data that have been provided, we see that there's an expected high number of node-negative patients in the target-only arm, 6 to 7 at least, and in the EBRT group, the group that received the EBRT after target, you can see that 34% of the patients were node-negative, but there were node-positive patients as well. So, as you would expect. Margins. The majority of patients had negative margins, but there was about a 5% patients in the group of patients that received target alone that had positive margins either for DCIS or invasive carcinoma. And as you can see, as you would expect, in the second column, the target plus EBRT arm, there was about 27% of patients that were that were margin positive, and that was likely the reason for them receiving additional radiotherapy. Again, that's an expected finding. There's still a lot of missing data regarding margins, so all of these numbers will change. But if you compare this to the Target A trial, there was a 9% positive margin rate in the Target A trial. And so at least this is in the same ballpark as you would have seen in the Target A trial. And now, before presenting the complications, I think it's useful to look at what was found in the Target A trial. The Target A trial looked at complications at the 6th-month time point post-target. The numbers have been published already, particularly in the first publication, the 2010 publication. And what you see here is for the first complication listed, hematoma, there was 0.99% versus 0.6%, no statistical difference comparing the target and EBT arm with regard to hematoma. We did see a significant difference in the seroma, incidence of seroma, but particularly seromas that required more than 3 aspirations. That's the caveat there. So in the target arm, 2% of patients required more than 3 aspirations for management of their seroma, compared to 0.8% in the EBRT arm, and that was significant, that difference. There was no difference in the infection rate. The numbers were low, about 1 to 2%. The skin breakdown was 2.7 in the target arm, 1.8 in the EBRT arm, but that was not significant. And there was a difference in the RTOG toxicity grade 2 or 3, lower in the target arm, higher in the EBT arm. But overall, there was no difference in the major toxicities when you compare the 2 arms. So that's really kind of the benchmark against which we would compare the results from the Target US registry trial. So this is what we found. With regard to hematoma, for the target group, actually, guys, I'm actually pointing at this screen, but I should be pointing at this screen here. So we see that there was a comparable amount of events, hematoma 2.9% in the target arm versus 1.8 in the group that also required EBRT. Those numbers were similar to what was seen in the Target A trial, and it was also similar to what was seen in the Target retrospective. As you remember, and I didn't address it earlier, but I just make the comment that there was a publication of Target retrospective, which is basically patients that receive that target that participated in that did not participate in the Target A trial, nor did they participate in the Target US registry trial. There was a group of about 900 people in the US treated around the country. Many of you were provided data to the Target retrospective. And the take-home metric to Target retrospective that even in an off-protocol setting, patients received had the same kind of outcome, same local recurrence rate, same event rate in terms of adverse events. And we're seeing that the pattern continues, that in the Target US registry trial, we're seeing the same rates of hematoma as we saw in the Target US registry, as we saw in the Target A trial as well. For seroma, again, seroma is an issue with APBI in general, also with Target. It was 9% in the Target only, 16% in the Target plus EBRT. In the Target R trial, they reported 9%. For those that required at least 3 aspirations or surgical management, in the Target group, it was 2.1 versus 6.1 in the EBRT group. So again, for patients receiving Target, seromas may happen. The number of patients requiring more than 3 aspirations is low, but it is more common in those patients receiving Target compared to EBRT alone, based upon the Target A data. Wound infection, again, the numbers are generally low, 2.3 versus 6.1, and we don't have comparable data to compare for wound infection, but when you look at the specific factor of wound infection requiring IV antibiotics, which is where we do have comparative data, it was 0.7 for Target, 0% in the Target and EBRT group, 1.9% in the Target A trial, and 2.7 in the Target retrospective. So you see a low incidence of patients requiring antibiotics for infections resulting from Target. Skin breakdown and delayed wound healing are shown. In the Target A trial, those 2 factors were combined to total 2.9%, 2.8%. But again, what we see now in the registry trial and what we saw in the Target A trial, they're comparable numbers. So again, the non-randomized experience seems to mirror the randomized experience. So in conclusion, this is what I can say about the trial so far, that the accrual is nearly complete. In fact, we are over-accrued. That the trial is slated to close in August of this year. Maybe a decision will be made to continue it. I can't say at this moment. The complications that we see in Target A and Target R are similar to what we saw in what we're seeing in the Target US registry. Seromas are an issue. I've already raised that, but the number of patients requiring multiple aspirations is low. We do have a lot of patients for whom we have collected data, but a lot of data are currently incomplete, and follow-up is also short, so can't really say much about the local recurrence rate. But what I can say is what we know about it so far is that it seems to track what was seen in the Target A trial at this time point.